Good morning and welcome to this meeting of the Physician Focused Payment Technical Advisory Committee, known as PTAC. Welcome to members of the public, whether you're joining us via WebEx, the phone, or live stream. Thank you all for your interest in our meeting today. We extend a special thank you to stakeholders who have submitted proposed models, especially those who are participating in today's meeting. This is PTAC's 11th public meeting that includes deliberations and voting on proposed physician-focused payment models submitted by members of the public. Because of the coronavirus pandemic, we are holding this meeting virtually rather than gathering in the Great Hall of the Humphrey Building. Our goal is for a seamless virtual experience as close to an in-person PTAC meeting as possible. That said, we appreciate your understanding in advance for any technical challenges that may arise, such as sound delays or background noise. To echo some of what we shared at our public meeting in June, we want to thank providers, support staff, caregivers, family members, and others who are supporting patients during the pandemic. Many PTAC stakeholders are directly involved in responding to the pandemic, and we are thankful for your service to our country. We recognize that it is a privilege to have some of you joining us today. PTAC remains committed to having a submitter-driven process. As was mentioned in June, given that many potential future submitters may be directing their time and attention to efforts related to the pandemic, anyone who is considering submitting a proposal should be aware that PTAC accepts proposals on a rolling basis, so you do not need to worry about finishing your proposal to meet a particular deadline. There is much to be learned about how alternative payment models can facilitate provider resilience. During the pandemic, we have learned a great deal about the critical role that telehealth has played in providing access for patients and payments to providers. There are lessons to be learned regarding the important challenges that emerge from the use of telehealth, including technical and functional challenges that can impede access to care and perpetuate disparities. Many previous submitters have included telehealth in their proposed payment models. We have organized the agenda for tomorrow's portion of the meeting to discuss telehealth in the context of alternative payment models. The panel discussions and the public comments provided tomorrow will serve to further the depth and breadth of the committee's and stakeholders' knowledge on this topic. Next, I'm excited to welcome our three new members to the committee. We have Dr. Jay Felstein, an emergency medicine physician by training. He is the president and CEO of the Philadelphia College of Osteopathic Medicine. Welcome, Jay.
Thank you.
We have Ms. Laura Harden, a nurse by training. She is the Senior Advisor for Partnerships and Technical Assistance at the National Center for Complex Health and Social Needs, an initiative of the Camden Coalition of Healthcare Providers. Welcome, Lauren.
Thank you, Jeff.
We also have Dr. Josh Liao, an internist by training. He's the Medical Director of Payment Strategy at the University of Washington Medicine, Director of the Value and Systems Science Lab, and Associate Professor of Medicine at the University of Washington School of Medicine. Welcome, Josh. And he may have stepped away because he's recused for this morning's session. We're thankful that they have all joined us. We welcome them to the committee. They were appointed by the Government Accountability Office in July and have hit the ground running. By learning all things PTAC and immersing themselves in the proposals we will be deliberating and voting on today. Now I want to update you on PTAC's work over the last few months. At our previous public meeting in June, we deliberated on two proposals, one from the University of Massachusetts Medical School and another from the American College of Allergy, Asthma, and Immunology. We recently released our reports to the Secretary for those two proposals, and you can find those reports online. We also released a set of questions on the For Public Comment page of the ASPE PTAC website on various topics such as current challenges in healthcare delivery and payment, to collect information that will serve to enhance the environmental scans that are conducted as part of our proposal review process. We intend to post the responses we received online. We're grateful to our stakeholders for their engagement as we seek to improve our processes We welcome further input on those questions at any time. As you may know, to receive updates about these various ways to engage with our committee, please join the PTAC listserv, which you can find on the contact page at the ASPE PTAC website. To remind the audience, the order of activities for review of a proposal is as follows. First, PTAC members will make disclosures of any potential conflicts of interest. We will then announce any committee members not voting on a particular proposal. Second, discussion of each proposal will begin with a presentation from the Preliminary Review Team, or PRT, charged with conducting a preliminary review of the proposal. After the PRT's presentation and any initial questions from PTAC members, the committee looks forward to hearing comments from the proposal submitters and the public. The committee will then deliberate on the proposal. As deliberations conclude, I will ask the committee whether they are ready to vote on the proposal. And if the committee is ready, each committee member will vote electronically on whether the proposal meets each of the Secretary's 10 criteria. After we vote on each criterion, we will vote on an overall recommendation to the Secretary of Health and Human Services. And finally, I will ask PTAC members to provide any specific guidance to ASPE staff on key comments that they would like included in the PTAC's report to the Secretary. A few reminders as we begin discussion of today's first proposal. First, if any questions arise about PTAC, please reach out to staff through the ptac@hh.gov email. Again, that email address is ptac@hh.gov. We've established this process in the interest of consistency in responding to submitters and members of the public, and appreciate everyone's cooperation in using it. I also want to underscore 3 things. PRT reports are reports from 3 PTAC members to the full PTAC and do not represent the consensus or position of PTAC. PRT reports are not binding. The full PTAC may reach different conclusions from those contained in the PRT report. And finally, the PRT report is not a report to the Secretary of Health and Human Services. After this meeting, PTAC will write a new report that reflects inputs from the public, as well as PTAC's deliberations and decisions today, which will then be sent to the Secretary. PTAC's job is to provide the best possible comments and recommendations to the Secretary, and I expect that our discussions today will accomplish this goal. I would like to thank my PTAC colleagues, all of whom give countless hours to the careful and expert review of the proposals we receive. Thank you again for your work, and thank you to the public for participating in today's virtual meeting. At this time, I'm going to turn over the virtual gavel and facilitation duties to Grace, PTAC's Vice Chair, because I am part of the PRT for the proposal we are about to deliberate on. Over to you, Grace.
Thank you, Jeff. Good morning, everyone. The first proposal that we will discuss today is called the Medical Neighborhood Advanced Alternative Payment Model. It's a revised proposal from the American College of Physicians and the National Committee for Quality Assurance. PTAC members, let's start the process by introducing ourselves and at the same time, read your disclosure statements on this proposal. Because this meeting is virtual, I will prompt each of you. So I'll start. I'm Grace Terrell of Aventis Whole Health. I'm a fellow of the American College of Physicians. I pay dues annually and participate in their continuing medical education opportunities. I was the first NCQA Level 3 patient-centered medical home in North Carolina in 2007. And in 2015, I spoke at the NCQA Quality Talks Conference, but for no remuneration other than travel and lodging. As Jeff mentioned earlier, Josh Lau has a scheduling conflict and will join the deliberations part through. I will read his disclosure statement at this time. I currently serve on several national ACP committees, including those related to medical quality, coding, and payment policy. While I did not participate specifically in the creation or submission of this PFPM, and there or no financial conflicts of interest, a reasonable individual would view my committee involvement with ACP and corresponding discussions about alternative payment models as an inability to remain impartial. I recuse myself from the review, deliberation, and voting of this proposal. Next is Jeff.
Hi, Jeff Bailitt. I am the CEO of Alteus. I have nothing to disclose.
Paul?
Paul Casal, cardiologist at Lead Population Health Initiatives at New York Presbyterian, Weill Cornell, and Columbia. Nothing to disclose.
Jay?
Hi, I'm Jay Feldstein, President and CEO of Philadelphia College of Osteopathic Medicine, and I have nothing to disclose.
Lauren?
Lauren Hardin, Senior Advisor for the National Center for Complex Health and Social Needs. I have nothing to disclose.
Kavita?
Hi, Kavita Patel, Brookings Institution, and I'm a dues-paying member of the American College of Physicians, but outside of PTAC, have not reviewed this proposal, and I've also done work with NCQA over the years, but not on this proposal.
Angelo?
Yes, I'm a pulmonary critical care physician and chief clinical officer for Prisma Health, and I have nothing to disclose.
Bruce?
Bruce Steinwald, a health economist in Washington, D.C. I have nothing to disclose.
Jennifer?
Hello, I'm Jennifer Weiler, Chief Quality Officer of UC Health Denver Metro. I'm also professor of medicine at the University of Colorado School of Medicine. Nothing to disclose.
Thank you, members. I would now like to turn the meeting over to the lead of the preliminary review team for this proposal, Kavita Patel, to present the PRT's findings to the full PTAC.
Great, thank you, Grace. And if we can go ahead and advance the slide. I just want to make sure I acknowledge the other members of the PRT, Dr. Sinopoli and Dr. Bailitt, and just also want to acknowledge that, as Grace mentioned, this was a revised proposal, and we had had participation in the past from previous PTAC members. Just to acknowledge that in addition to Dr. Bailitt, Harold Miller participated in that very first review, and wanted to thank everyone for being a part of that. Next slide. So we're just going to go over kind of the basics of the PRT and the proposal overview, a summary of our preliminary review team's assessment with some issues in our evaluation. Next slide. And as just a reminder, this is standard, the preliminary review team composition. So we are assigned 2 to 3, in our case, 3 PTAC members, with myself serving as the lead. And the PRT identifies if we need clarifying information from the submitter. All of this is in public record, so any additional documents are available to anyone watching or listening to this webinar. But then we as a PRT can determine if there is any initial feedback on a proposal, as well as after reviewing the proposal and materials assembled by ASPE and other public comments that were received, we prepare a report of our findings, which are also available to the public and posted on the PTAC website if people need a place to find them. The PRT report is not binding on PTAC members, including the PRT members, by the way. So the PTAC itself, including the PRT members, might reach different conclusions from those contained in the preliminary review team report. The keyword there is preliminary, and just a way for framing the discussion. Next slide. All right, so in order to just do a little bit of background, we wanted to offer, this was I really wanted to thank the submitters, as well as those of you that did provide public comments. And again, just the ability to, as an example for anybody interested in submitting proposals to PTAC, this was a case where I think the initial feedback that's been afforded to us by regulations and authority was able to help to really refine this proposal and bring it to what we are presenting today. Rather than read the slides, and I know there are people just listening on the phone, I'm going to hit the highlights so that we have a sense of what this model involves. It's a 5-year multi-payer pilot program that builds on a current CMMI program, the Comprehensive Primary Care Plus, CPC Plus and the primary care first models, which has not started but is slated to begin in 2021. And it incorporates the NCQA's guidelines developed on patient-centered specialty practices. The MNM, as we're going to try to refer to it, Medical Neighborhood Model, MNM, is really designed to address two key issues: the dearth of current specialty advanced payment models, and really this poor intersection between primary care and specialist referral coordination. So I think you've got a good exemplar of specialists and primary care physicians on the PTAC composition, but it was really helpful to hear perspectives from physicians and public comment to this point. Submitter proposes that the MNM be piloted in a subset of CPC Plus or PCF regions once they are initiated, with enough specialties so that there's kind of a high value and high volume electronic quality measures that can be used to actually monitor the MNM. And because of this need to start with certain specialties, the submitter proposes, but it's not binding, cardiology, infectious diseases, and neurology as potential initial pilots. So the APM entity, the goals are, as stated, to improve care for Medicare beneficiaries with multiple chronic conditions through the better coordination of specialty and primary care. And the APM entity would be specialty practices that have achieved an NCQA PCSP patient-centered specialty care practices. This is my acronym test recognition. Next slide. The eligibility for this, here we go. Sorry, I'm trying not to read off the screen and just go by my notes. But the eligibility for this, targeted beneficiaries would be eligible for attribution in this with multiple chronic conditions that include the specific conditions on which the model focused, for example, with some of those initial proposed specialties. The payment would be one of two tracks for which the entity could choose from. Track 1 would be a regular fee-for-service payment track, while track 2 would be reduced fee-for-service, a 25% reduction in fee-for-service, but in exchange for quarterly prospective payments that are risk-adjusted. Performance measures, as mentioned again, it's the NCQA PCSP recognition program, which has an incredibly comprehensive, detailed set of existing quality measures that have been validated. And the focus on those measures include everything from utilization, behavioral health, patient-reported outcomes, experience, and care coordination. Next slide. Core elements of the MNM program. There are three really critical core components, and this will vary a bit depending on that payment track that an entity chooses. There's a care coordination fee where all participants would receive a monthly per beneficiary fee to support the care delivery investments, as well as a potential kind of add-on performance-based payment on spending relative to a benchmark that's risk adjusted for quality and utilization metrics as well. Then there's a performance-based payment adjustment where all participants would also receive a performance-based payment, but it depends based on spending relative to a benchmark. This is for both tracks 1 and 2. And then the next third kind of major component is really for people who choose that track 2 of reduced fee for service. It would be a comprehensive specialty care payment, and that's a quarterly prospective payment based on estimates of anticipated or prospective Medicare fee schedule spending. So that's some of what we can go into. But again, there's a rich set of background and materials related to this in the public viewing folder. All participating specialty practice will get a risk and geographic adjustment, non-visit based per beneficiary per month care coordination fee on attributed patients. The care coordination fee, as I referenced in one of the 3 domains, is risk adjusted at the population level to account for intensity of care management services. Next slide. And then attribution, which is obviously incredibly important to this model, occurs in 3 steps. First, all referral requests from a CPC, remember these are people who are kind of, if you will, nested or centered in CPC Plus or PCF practices, All referral requests from CPC Plus or PCF, kind of primary care physicians, are pre-screened to ensure that there is an appropriate specialty visit. This is to mitigate unintended consequences. Second, if the specialist is uncertain whether a visit is necessary because they need more information, an optional e-consultation is conducted to determine whether an in-person visit is appropriate. I think all of us that are practicing in light of COVID can see how this is probably a lot easier than we would have anticipated than in prior days. Third, a patient for whom a visit is determined to be necessary has an office visit with the specialist. Next slide. And then just to go over, there we go, sorry. Summary of our PRT review. I think this is record setting. I'm one of the original PTAC members, and I can't recall a time when we had both unanimity and just not unanimity across the PRT, but unanimity in our conclusions. I'm not going to read this to you because every single criteria specified by the secretary of our 10 criteria unanimously we felt met the criterion. So this is something of a, Grace might correct me, or Jeff is one of the PRT members, but I can't recall something that had this degree of agreement. Next slide. But that's not to say, here's where I get to be bad cop to some degree, not in a bad way, but just to say that our unanimity didn't mean that there weren't some key issues that we identified. So we wanted to make sure that, there was an incredible importance in having this grounded in the CPC Plus and PCF programs, but there are reasons for which many providers don't have those opportunities. And we want to, just encourage the PTAC to consider that we brought this up and discussed it. And then we also think that this medical neighborhood model is an important approach, and that this could really be kind of a game changer, if you will. It's what some of us have kind of always thought of as the last mile in patient care, with improving care within and between specialty practices to avoid unnecessary care. But we do think that in order to make sure that this has as high of a probability of successful execution and implementation, that there may need to be some refinements. That, obviously the submitters were bound both by page requirements and just time constraints. So there are, clearly, if this were to go forward as the PRT felt it should, that we thought that there needed to be refinement, and that goes everywhere from some of the details on attribution to payment to risk adjustment to consideration, for example, of requirements around specialty measures. Next slide. The other things that and I touched on some of the key aspects that we thought needed to be developed further. So I'll say that despite some of those issues that we do feel need refinement and further discussion and deliberation beyond kind of the PTAC, we thought the M&M proposal itself gave sufficient framework and mechanisms to justify the consideration, thus our unanimity in, kind of all the 10 criteria. And that we thought that, a specialty APM in and of itself could not achieve like a threshold of large savings for model development and implementation. For example, an infectious disease APM potentially, or a neurology APM in and of itself. But that having this model that allows for kind of potentially a hub and spoke with primary care and specialties, as is kind of consistent and common in regular practice, that we felt like this was why the M&M model really was it's why we voted the way we did. And then if this is, and I think the key here is that the ACP and NCQA really proposed this as a pilot. So they proposed it as a pilot with kind of an initial strategy for those 3 specialties, cardiology, neurology, and infectious diseases. Then if that were to be defined, executed, and potentially piloted, that then there could be an opportunity for additional specialties. Next slide. And then just to go through, I'm, again, not for the sake of reading, but highlights on this, that the criterion 1, which was one of our high priority criterion around scope, that this proposal we felt unanimously met the criterion because it did provide an opportunity for more people to participate in APMs, particularly specialties who might not have an opportunity otherwise. And it leverages at least two existing CMMI APNs. We don't know if the referral volumes to some of the the specialty practices from these primary care groups that are in CPC Plus and PCF might be large enough. So that was something that we brought up. And that we also know that if there are specialty practices who do not have NCQA PCSP recognition, which is proprietary and not open source, that could be a barrier in joining easily. Next slide. Scope 2, criterion 2, which was also high priority quality and cost. It calls for we again felt unanimously, the PRT, that it met this criterion and that at no additional cost that we thought that this could improve quality. It really uses existing evidence-based measures. And one thing that might, because of this proprietary nature of the PCSP, there may be a consideration for an alternative approach to achieve those same domains and measures. One thing we just wanted the submitter kind of proposes that CMS really kind of help with clinical quality improvement through regular performance feedback to participants, including meaningful benchmarks so that you compare yourself to others as well as kind of a control group. But we think that because of the model's increased payments, it may be difficult to offset some of this through downstream savings. So just to the point of cost, that we think that there's, again, more work that could be done on the suggested 2 tracks, but in terms of meeting the criterion, we felt that it did, and also wanted to acknowledge some of the difficulty potentially with model overlap with people who are in CPC Plus or MSSP programs, ACOs, et cetera. Go ahead and next slide. The third criteria, also a high priority one, payment methodology. We touched on some of the issues that need to be further addressed if the PTAC moved this on beyond this process. But we did feel unanimously that this addressed a pretty important challenge of how to adjust for specialist time, for appropriate referrals, kind of for necessary care, including the necessary time coordination with primary care physicians to incentivize kind of that appropriate appropriate initial and subsequent referrals, as well as closing the loop on referrals when you no longer need specialty care. And that without really having, again, we think that some of the attribution methodology could use further discussion and refinement, but we felt like it was sufficient, in fact, met the criteria in a way that we thought handoffs between providers, we thought that handoffs, especially if there were duplicate shared savings payments, could be problematic, but we think this can also be dealt with through thinking through a little bit further on the attribution and payment methodology. We also, the model expects that if you are a specialist participating in this model, that you'll use that care coordination fee for infrastructure investment, might be technology, might be further care coordination staff. But the CPC Plus model already includes those care management fees, and just the published literature to date has not shown cost savings from those care coordination fees. Another issue that we brought up was that downside risk is not incorporated into this proposal. Track 2 does have that reduced fee-for-service payment, which especially for many providers, because it's a reduced fee-for-service payment within a quarterly prospective payment, that one could argue that in some way that is a bit of downside risk. But again, there is not kind of what's been seen in previous APMs with a direct downside risk track. And then finally, half of the performance-based payment benchmark would be based on regional spending, and there is a methodology to include that payment to be risk adjusted, but that benchmark itself could be very difficult to define under a general formula to serve as kind of the counterfactual spending target, meaning it's comparisons of potentially apples to oranges with regard to a benchmark based on regional spending that is risk adjusted, and finding kind of even in a control group how to compare that. And that's also come up with previous models. So, but given all those areas, we still felt that this was, again, going to the top point, an incredibly valuable payment methodology to address this kind of last mile between coordination of primary care and specialties. Next slide. Fourth criterion, value over volume, felt that unanimously felt that this met the criterion because if this is done correctly and attribution payment, risk adjustment, quality measures, that this really is intended to reduce inappropriate use of specialty referrals or even the kind of downstream or upstream duplicate testing and diagnostics that can happen when trying to coordinate primary care and specialty care. It does allow the specialists to kind of select quality measures, which could lead to cherry picking. So we wanted to just flag that. And again, this is, I think, a point for consideration if this were to move into what we recommend into the pilot phase as suggested by the submitter. And it will be, all of this is kind of contingent, everything is linked to the payment methodology being further detailed, attribution methodology being refined, and making sure that the true intention, the adequate coordination between specialists and primary care really does happen. But we felt that because the submitters had suggested an initial set of specialties in a smaller, what we call pilot phase, that there's an opportunity to refine these issues. Next slide. Criterion 5, flexibility. This, again, the initial phase, which is described as a pilot phase, after that period of time, whatever that might be, there is a recommendation to allow for multiple specialties, which we thought could be an incredibly flexible model. And also it involves potentially the door to be open for specialists to benefit from these kind of one-time consultations and ongoing collaborations with primary care practices. The submitters did suggest that the proposed model could be expanded over time, basically to any specialty that has a sufficient, kind of high value electronic clinical quality measures and referrals from CPC Plus or PCF practices. But we noted, the PRT noted that small specialty practices in particular might find the PCSP recognition itself from the NCQA a bit too costly and burdensome, which is why we brought up some of the potential for alternatives to that, or at least consideration. And the volume of patients in smaller practices might also be insufficient in small and rural small urban settings and smaller rural settings. Next slide. Criterion 6, the ability to be evaluated. Submitter acknowledged in their proposal the recommendation of an independent third-party evaluator, which is generally now considered standard practice for most CMS-type models. So, but the submitters had some nice recommendations around the kind of targets for these evaluations, including the data sources. We noted also that, again, there's a lot of dependency on sufficient volume, and we thought that maybe that there needed to be at least 100 patients attributed to the entity to trigger those monthly care coordination fee payments. But it's not necessarily clear from the proposal if there is a statistical calculation based on, entity size, et cetera. So we're not sure if this kind of number of 100 is, one, appropriate, but number two, sufficient or attainable by participating practices. Next slide. Integration and care coordination, also, again, unanimous agreement that this met the criteria because this is essentially the goal of the program to encourage greater coordination of care. And while just at one issue that we discussed as a PRT, it doesn't necessarily go through the how-to or the steps that a specialty practice needs to undertake to improve care coordination. Next slide. Criterion 8, patient choice. This model does not restrict patient choice of specialty care, and we noted that the participating practices being part of a PCSP should result in greater access to specialty care because of this anticipated hopeful reduction in inappropriate referrals and inappropriate visits. But again, the process for attribution of patients could be a challenge. And that's why reinforcing the submitter's suggestion to have a pilot was one of the reasons that we felt very comfortable kind of unanimously agreeing for this criterion as well. Next slide. Criterion 9, patient safety. There are multiple, what I would call checks and balances on maintaining patient safety. And again, I think the NCQA's PCSP model has a very rich set of measures that are dedicated to the domain of patient safety and patient-centered outcomes, with monitoring suggested for the M&M model, everything from CAP surveys on electronic quality measures, and also using administrative claims, Medicare claims, as well as commercial payer claims on quality and utilization. But it's not entirely clear. This concept of an e-consult, while it might be a little bit more and kind of inoculated during an era of COVID, not entirely sure how we would have kind of a standardized, e-consult appropriateness of care. So we just wanted to flag that. Next slide, final criterion, health information technology. You can tell there is a rich set of what I'll call electronic-based processes that this model would require, everything from using just the basic certified EHRT, which was one of our sub points for this criterion. And also having multiple options for sharing and reporting data entry into EMRs, designed really to hopefully reduce administrative burden on providers. And there could be, the requirement would be uniform kind of electronic data exchange standards, so that there's not as much of this interoperability kind of between EMR negotiating. And but given all that, there's acknowledgement that some even certified electronic health record technologies might not actually be able to do that. And there might need to be some of that infrastructure investment, which usually gets put on the practices to improve coordination. So this is in our PRT report, but we just wanted to kind of make sure that while there's so much importance put on data exchange, that it's not coming at the undue kind of or disproportionate burden to the participants. And next slide. So that concludes our presentation from the PRT. I'm going to stop here and ask, I mentioned I've got Jeff and Angelo, who were my co-pilots on this journey, and of course the amazing ASPE staff and NORC staff. But I'll ask maybe Jeff, start with you. Any additional comments, things that I missed to flag, or things you want to just emphasize?
Thanks, Kate. That was a great job summarizing the work on our committee and the proposal. Two comments I would make. One is I compliment the proposal submitters for their diligence and stick-to-itiveness, that they revised their proposal. We had a rich discussion with them, and the revised proposal reflects a lot of the learnings from that initial exchange. The second thing is, I think one of the key issues that you touched on, Kavita, this proposal really does two things. It creates an interface. It addresses an interface between the specialty and primary care community that really can drive up costs and impinge quality, because it really gets to this transition between making an appropriate referral to a specialist and ensuring that all of the information, including the need to refer the patient to a specialist, is done on the front end. That coordination is critically important, and it's been clear that when that breaks down, it drives up costs and impugns quality. So that's critical. And the other comment I'll make is that these proposals still, as you suggested and the submitters acknowledge, Kavita, they're imperfect, they're not complete, but we felt this proposal creates a broad enough framework to break through what we've been looking for in several of the evaluations. It creates a forum for specialists to participate in alternative payment models, and we think that the framework is sufficient in coordination with CMMI and CMS, that it will hopefully serve as a framework that can actually be constructed for alternative payment models for specialists. And it goes in with select specialties, neurology and cardiology and infectious disease. It goes in at a level where there's It allows for testing, but it also is robust enough that I think the framework coming out of that could be offered to many other specialties. So thank you.
Great. Thanks, Jeff. Angelo, any comments to add, things to highlight?
Just a few short things. So first of all, Kavita did an excellent job describing this proposal and all the details involved and captured the PRT sentiments regarding this. I do think it's significant that the PRT had unanimous positive evaluation of all the criteria for this proposal. So I think that is significant. I think as a specialist, I reiterate too that these are real issues. I see them every day with patients being referred, and you see in patients have inadequate data. So either it's a wasted visit or you wind up repeating studies that didn't need to be repeated. So it is a significant cost and quality issue that needs to be addressed. I think it's also significant that, as Kavita and Jeff pointed out, there are a lot of areas where there was concern or questions about how this proposal might be further developed and further refined. We think there's a lot of opportunity to make this a more effective model. But I think the things that really drove my decisions around this is that this is a proposal that gets specialists involved in these APMs, and really the intent is to get the specialists and primary care doctors coordinating care together in a better way. And I think the other issue that made me feel more comfortable with this is that from the onset, they described this as a pilot. So it's not that it's necessarily being pushed forward as a permanent full alternative payment model, but they realize that this needs to be piloted, some things worked out, evaluated, and then potentially scaled down the road. Thank you.
Great. And Grace, I'll ask now if we want the full PTAC to ask any questions of us, the PRT, before we get to.
Yep, so just to remind everybody, these are for clarifying questions, details about the actual proposal itself. Should you have the opportunity to do once the submitters have had a chance to comment. So we will do this through our process of who's raising their hand. And I believe that I see that Bruce's hand is raised. Is that correct?
Yes, this is a test. I guess my question is, since this is a resubmission, what are the major ways in which this proposal differs from its predecessor?
I can go through. We had just out of fairness to the fact that not all the current PRT was on the lab. Angela wasn't part of that first deliberation. I would say that our initial feedback really was to further refine the payment method. It was all the domains that we had flagged for honestly querying questions and further elaboration. So attribution, payment methodology, clarification on measures, and including, I think, this concept of a pilot with an initial phased rollout. So it just in general, they strengthened and added the kind of what we felt like was necessary detail. Remember, we weren't giving them technical feedback. It was just initial feedback based on that proposal. That being said, I would just ask the full PTAC to really judge it based on what you see in front of you and not necessarily worry as much about the first deliberation. I really more just wanted to acknowledge that this was something that was revised and that we had a member of PTAC who was on that first PRT who's not here.
Okay, thank you.
So I believe that Jennifer Weiler is next with her hand raised.
Thanks for the excellent summary of really comprehensive model, and so appreciate the comments. I'd like to hear a little bit more about the PRT's opinion regarding no downside risk in this model, and how you thought about that in the context of a high priority characteristic. You commented on it, but just wanted to give a little bit more space to to hear more about that.
Yeah, I'll go ahead and start. I mean, and I think this might be where, even though we were unanimous in our kind of our voting, we each probably have different reasons for what this means. I will say that having now studied probably every alternative payment model known to mankind, I have not seen yet a model that has initial downside risk. When you have a model that is incredible implementation, execution, attribution, risk adjustment, quality measurement, that having kind of an initial downside risk immediately, often we have now counter example after example where it has very little uptake and in some ways kind of sets model participants up to fail. So I will say that my viewpoint on not having some sort of downside risk as a potential flag was really more that I think we're going to face the need to not have models that just look like they're handing out coordination fees without any accountability. Having said all that, I think that this model has such a tremendous amount of measures, accountability, evaluation, feedback, benchmarking that I wasn't as concerned about it. So that's my opinion. I'm sure Jeff and Angelo have different kind of maybe perspectives.
And I see that Angelo's hand is up now.
Yeah, thank you. So I would agree with Kavita's evaluation of that. I think this is being viewed as a pilot, and there's a lot of issues to be worked out. And so I think putting participants at downside risk as we're trying to work, or they're trying to work through the nuances of what makes this model work better, I think would prevent a lot of people from participating. And so I think at some point as we move forward, I would expect that this would have downside risk, but probably not until a little more refinement in the model gets accomplished.
Gita, this is Jeff. I agree with your assessment and Angelo's. I'm looking at it and viewing it the same way. Thank you.
Other questions? I'm not seeing other hands right now. I'll give it a minute or a second or two just to make sure. Okay. Well, hearing none, all right, let's go ahead and have the proposal submitters join us. We have 4 representatives from the ACP and 3 from the NCQA joining us via WebEx. If you guys will introduce yourselves, I know you want to make some opening comments, which we're going to limit to 10 minutes. That's all together with all of you. And then we're going to open it up for questions. And so I'm going to thank you guys for being here. So first one, I believe, is from the ACPE, Sherry Erickson, Vice President of Governmental Affairs and Medical Practice for American College of Physicians. Are submitters on there yet?
Thank you. Yes, would you like me to go ahead and make opening remarks, or would you like me to, or our team to introduce ourselves first?
Yes, if you could just introduce yourselves. So there's so many of you. I didn't know if you were going to introduce your individual folks or whether you're just going to go on one by one, but you were the first on the list.
Great, thank you. I appreciate the introduction. You already mentioned my title, Vice President of Governmental Affairs and Medical Practice at the ACP. I'll actually defer to my colleagues to each introduce themselves on the webinar. So Brian Outland, if you could go next.
Yes, I'm Brian Outland. I'm the Director of Regulatory Affairs at the American College of Physicians, ACP.
And I believe
and next up, Amir Kassim, Dr. Kassim. Perhaps she's not on as a presenter yet. So Suzanne Joy, could you introduce yourself, please?
Hi, yes. Hi, everyone. My name is Suzanne Joy. I'm on the ACP Regulatory Affairs team, and I work heavily in the value-based payment world. So very excited to be here and appreciate the opportunity. Thank you.
Thanks, Suzanne. And then also Samantha Tierney, if you could introduce yourself, please.
Yes. Hi, everyone. Good morning. I'm Samantha Tierney. I'm a senior scientist with the clinical policy team.
So thanks for the ACP team. Is there anyone else from your team?
Hi, this is Michael Barr. I'm the Executive Vice President for Quality Measurement and Research at NCQA. Thank you, Grace. And let me let Joe Castiglione introduce himself, as well as Paul Cotton.
Hi there, Joe Castiglione. I work in strategic initiatives for NCQA. Thank you.
Paul Cotton, are you there? I know he's struggling between two meetings, so he might join us later. Back over to Sherry. Thank you, Grace.
Okay, and I believe now you're going to have, Sherry, you're going to go the first 5 minutes, and then Michael the second 5 for your presentations. So we look forward to hearing what you have to say.
Great. Thank you, Grace. Really appreciate the opportunity to present our model and appreciate the hearing from PTAC as well as our PRT team. It's been a great opportunity to provide input along the way and through both submissions of our model. And so we look forward to hearing from the PTAC, answering your questions, and seeing this through the process. So the teams at the American College of Physicians and NCQA have been actively collaborating to develop something we believe will be a meaningful opportunity for specialty care internists and other physicians to engage in value-based payment efforts. I believe this model offers an on-ramp to advanced APMs that can apply to multiple specialties and is not limited to any one type of clinical condition. The American College of Physicians represents 163,000 internal medicine physicians. About half of our membership are subspecialists. So there's a lot of collaboration that goes on within our own membership, as well as our members with other specialties. We first started down this road 10 years ago when we published our policy paper titled The Patient-Centered Medical Home Neighbor, the Interface of the Patient-Centered Medical Home with Specialty and Subspecialty Practices. Unfortunately, since that time, there are still limited opportunities for specialty practices to engage with their primary care colleagues in a manner that appropriately rewards both for excellent care. Therefore, this payment model has been created in a manner that builds off successes of the Comprehensive Primary Care Plus model and the upcoming Primary Care First model, and engages specialty clinicians with primary care partners to transform into medical neighborhoods. This is, as Dr. Patel mentioned, a 5-year multi-payer pilot that would operate in CPC Plus and Primary Care First regions. The main focus of this model is on improving patient care, particularly those with multiple chronic conditions. It does that in a few different ways. First, by ensuring that practices meet advanced standards that are intended to improve primary care and specialty practice coordination. 80% of serious medical errors involve simple miscommunication during handoff between clinicians, according to research. Additionally, referral issues can lead to a high severity of harm in 83% of cases. The model also includes a unique pre-screening step to cut down on unnecessary specialty visits. This saves time and money for everyone, and eventually we believe will reduce specialty wait times, thus improving access for patients. 8% of all specialty referrals are inappropriate with medically unnecessary or with the wrong specialty. And nearly half of all specialty care appointments are routine follow-up appointments, some of which can be delivered in a primary care setting with the same or better quality outcomes. And additionally, this model utilizes high validity performance metrics that hold clinicians accountable and incentivizes better outcomes, patient experience, and efficient resource utilization. All participating clinicians must meet national average to share in any performance-based payment adjustment. And unlike other models, higher performance score, the more of this payment, performance-based payment adjustment they can retain. The key is a payment structure that supports these objectives, which was discussed earlier. There is a per member per month care coordination fee that's intended to support meeting advanced practice transformation standards and better care coordination with primary care partners to improve patient outcomes. I believe this is important for stability, something we've learned, I think, particularly given the impact on practices who are participating largely in fee-for-service environment within this pandemic. Performance-based payment adjustment is the second component of the payment model. It holds clinicians accountable and incentivizes meeting robust quality and financial targets based on high-value performance metrics. This payment features flexible risk options, a choice of a symmetric savings and loss rate of 0 to 2%. And those who choose higher levels are intended to qualify as the advanced APM participants. And finally, there's an optional prospective payment for those that choose Track 2, which we call the comprehensive specialty care payment in exchange for reduced fee for service payments, and this was discussed earlier. I also want to hit on a few of the model's strengths and the needs that it addresses. We believe that this model can reduce administrative burden by encouraging the adoption of certified electronic health records and electronic clinical quality measures. The measures are also intended to be aligned across payers, which is a significant burden for practices today. And we anticipate waiver flexibilities such as reducing prior authorizations, et cetera, that can also reduce administrative burden within the practices. We believe this is a fully scalable model. It is multi-payer. It aligns incentives across the payers and can apply to a broad range of specialties. It also aligns with the planned transition to MIPS value pathways, or MVPs, within the quality payment program that are planned to be implemented in the coming year. And additionally, I want to note that this promotes the use of telehealth through e-consults and virtual check-ins. I think the current pandemic has shed light on the importance of telehealth, which I believe the PTAC will be discussing tomorrow, to providing ongoing care to patients when and where they need it in the safest manner possible. So even when the pandemic wanes at some point, the delivery system, I believe, will be forever changed due to what we're learning now. And telehealth will be a key component of that evolved system. Therefore, models such as ours that promotes the use of multiple modalities of care is critical. So at this time, I'll turn it over to Dr. Michael Barr with NCQA to continue to introduce our model. Michael?
Thank you, Sherry. Let me add my gratitude for the opportunity to discuss this proposal with the committee, and thank you to the PRT for your initial review. That helped us immensely with the resubmission. I don't think we can underestimate your feedback, and thank you. And as Sherry outlined, we're really proud of the collaboration between ACP and NCQA, and I'm especially thankful for the opportunity to work with Sherry. She and I previously collaborated when I was on the staff at ACP to help bring the patient-centered medical home policy to life, and it's been great to gather our respective teams around this effort to create an advanced APM proposal for specialists. Now, this is a unique collaboration between a leading medical professional society and NCQA, but it's not the first time ACP and NCQA have collaborated. In fact, when I was at ACP, we worked with NCQA to develop the first PCMH recognition program. And that was an effort spurred on by the response of employers and insurers to the PCMH concept. They wanted to know which practices were adhering to the attributes of the medical home so that they could consider paying those practices differently. That same approach is applied to the patient-centered medical home neighbor policy referenced by Sherry. Just as the first PCMH recognition program was built to support the need for employers and payers to differentiate primary care practices, the patient-centered specialty practice program, a key component of our proposal today, was created by NCQA with input from ACP and other key stakeholders. In fact, the policy underlying this proposal, as well as the payment model and recognition program, were all developed with input from key subject matter experts and committees at our respective organizations. We believe that the entry point to this payment model should not be based on attestation. That demonstration of key attributes provides assurance that practices are ready to take accountability for the robust coordination, communication, and most importantly, effective care this model is designed to promote. Unlike NCQA's native PCSP program, which does not require the submission of electronic clinical quality measures, this proposal specifically requires electronic quality measure reporting. And in other words, PCSP recognition is the foundation, the measures, the assessment, and the payment model, the motivation to continuously improve. And with respect to the measures, we believe a core set of cross-cutting measures supplemented by specialty-specific or condition-specific measures within the specialty of interest will help curtail cherry picking. And alignment across participating practice in each involved specialty will facilitate analysis and benchmarking. The proposal relies upon electronic reporting exclusively in order to minimize burden and leverage the rich clinical data in electronic health records, specialty-specific registries, and other electronic sources. Since the PCSP program is essential, let me spend a bit more time describing it in some detail. It is the only national program of its type, and along with the PCMH program, the PCSP is recognized as an improvement activity in the CMS Quality Payment Program, and the PCSP is the only MACRA-approved specialty practice recognition program. And what does it include? It's 7 domains, and I'll go through them quickly to highlight some key practice attributes that align very well with the purposes of this model. First, the team-based care and practice organization is the practice is set up to succeed in terms of defined roles, responsibilities, training, and communication in team-based care. Does it involve patients and families and practice governance or stakeholder committees? Initial referral management. Does the practice coordinate with primary and referring clinicians? Does it set expectations for information sharing and close referral loops? Knowing and managing your patients, does the practice capture and analyze information about the community it serves, provide culturally and linguistically appropriate services, address medication management and safety within the practice and through coordination with referring clinicians? Does it use clinical decision support to help guide care? Patient-centered access and continuity. Does the practice assure the appropriate levels of care are accessible, for example, to help avoid emergency department utilization? Plan and manage care. Does the practice do risk assessments and consider the needs of patients when developing care plans in coordination with them? Care coordination and care transitions, including management of secondary referrals, tracking and follow-up of diagnostic test results, and so on, and then performance measurement and quality improvement. Essentially, does the practice have a culture of data-driven performance improvement on clinical quality and patient experience metrics, and engage the staff, patients, families, caregivers in those efforts? Now, we understand the concern that small practices might have challenges with the PCSP program. However, let me just say the average size of an NCQA PCSP site is 5 clinicians. So we anticipate that small practice sites will be able to actively participate in the M&M. In fact, small practices might actually have an advantage over large ones. Once they commit to do the work, there aren't multiple levels of approval to secure, and changes can be implemented reasonably quickly if a practice is prepared to act. There are over 530 sites and greater than 3,100 clinicians recognized by NCQA, including specialists in cardiology, neurology, hem-onc, endocrinology, pulmonary medicine, rheumatology, gastroenterology, infectious disease, neurology, and some non-internal medicine specialties, including orthopedics, urology, dermatology, and obstetrics and gynecology. This demonstrates that the PCSP is sufficiently flexible to accommodate a variety of medical specialties and surgical specialties, and this is a key strength of the M&M because it is scalable to additional specialties which lack meaningful APM opportunities. And of course, the CPC Plus and Primary Care First participants naturally make excellent partners in the medical neighborhood. Many of these practices are themselves recognized as NCQA PCMH practices and have complementary care coordination processes in place. In closing, in 2006, when ACP released the Advanced Medical Home paper, it reinvigorated the concept of primary care as the foundation for a better healthcare system. However, we knew then, as we know now, that primary care alone cannot improve quality and reduce cost. The ACP Medical Home Neighbor Policy was recognition of that fact, and here we are now with a chance to link primary care with specialty care in a robust test of the premise that by working together, they will be more effective at improving care for people, reducing harm, and wringing out unwarranted variability and inefficiencies that add tremendous cost to our healthcare system. On behalf of ACP and NCQA, let me say that we are committed to work on the issues that were identified by your review, and thank you very much for the opportunity to speak today.
Thank you both, Sherry and Michael. I'm now going to, at this point, to open it up for my colleagues who would like to ask some questions. Again, since we're in a virtual format, I will be calling on each of my colleagues who have indicated that they have a question or comment. Each of the committee's questions will be directed to Sherry Erickson for ACP and Dr. Michael Barr for the NCQA, who will determine who from each of their teams will provide the response. In the event that one or more committee members provides comments relating to the proposal without directing a specific question to the submitter, please notify PTAC staff if someone from ACP NCQA team would like to provide a response, and the chair or the vice chair in this case will give you an opportunity to share your response. So I am going to give my colleagues a moment to see what, to put up their hands, and I'll start calling on folks. You don't put up your hands, I've got some questions. Okay, well, I'm going to start then while
Great.
my colleagues are thinking about it. Or am I missing somebody here?
I have my hand up. It's
Oh,
Paul.
there it is. Got it. Paul does, and now I see Lauren. Okay, it must be a little lag here. Well, Paul, I'll start with you, and then we'll go to Lauren.
Great, thank you. And thank you for those comments. They were very helpful. Just a couple of questions, two questions. One is, I appreciate the advantages of the PCSP recognition program, and no doubt, and you commented that it was essential to the model. One of the concerns, at least we've heard from CMMI in the past, and we've seen other models with sort of proprietary, either software or pieces to it where clinicians have to pay to participate. And CMMI in the past has been reluctant to consider that. And I know in the questions that the PRT had asked you was, can you participate in this without being part of the recognition program? And at least in the answer, what I saw was highlighting the advantages of the program, which I understand, but I wasn't sure I saw a clear answer as to whether you could participate without being part of the recognition program.
I'll take that. Thank you. And then Sherry, feel free to comment. I think it's from our experience with the PCMH and so far with the specialty practice program, as I said, we don't think attestation, simply saying a practice is doing something, is going to be sufficient for us to put the accountability on the practices. It's, people think they're doing things, but unless they demonstrate that, they're not consistently applying the attributes of what we would like to see to justify the payment model. Now, does it have to be the PCSP program from NCQA? That's a valid question. I think that's the only program out there that's been MACRA approved. So without going with that, obviously we have a direct interest as NCQA, but the cost of the actual license to the program is far less than the work that a practice would need to do to actually adhere to the principles and drive towards the model we're trying to encourage. And the payments from this model would more than offset any direct costs and the license fee of the recognition program. And further, in the pilot program, both ACP and NCQA agreed to discount the fees significantly in order to help promote the model. And if another model exists and somebody wants to develop another recognition program, I suppose the committee could take that and CMMI could take that and decide if that's an equivalent. Sherry, do you have anything you want to add to that?
No, I really don't have anything to add to that. I think that answers the question.
Great. I just one other question, Grace, which was, specialists, in terms of engaging specialists in models, the current one is really the BPCI Advanced. And, as you probably know, last week, CMMI announced the move in model year 4 to sort of these episode service lines. And they've signaled that after in 2023, their intent is to make those mandatory, potentially. Is there any barrier for specialists to participate in BPCI-A as well as with the medical neighborhood model?
I think I'll ask Suzanne Joy on our team to answer that.
Sure. I think that's a really great point, and I think that model overlap is certainly going to become a consideration not only for our model, but for, as a model. And I think the general answer to those questions is that you have to look at the incentives, whether there could be differing incentives. So ours is a benchmark style model, and we do think that there is an added advantage to having a benchmark style model. And that's why we can see, for instance, that the MSSP model can overlap with CPC Plus, that is allowed, but CPC Plus, for instance, cannot overlap with other more similar models. So in regards to that question, I think we'd have to take a deeper look, but they do seem at base kind of different incentives for slightly different activities. The M&M is specifically to incentivize coordination across settings with primary care clinicians. So we certainly think there would be room to still separately incentivize, efficiencies further within the confines of the specialty practice. So I would say that we will, in that specific instance, specifically preclude it, but it's certainly worth taking a closer look. And that's kind of where I would put that. It sort of depends on the design of the models. And I'm happy to answer any additional questions.
Great, thank you. Thanks, Grace.
Thanks. Lauren, you had some questions, ma'am.
Thank you so much for this innovative and comprehensive proposal. I'm curious if you could articulate a little bit deeper, what is the difference? What difference do you anticipate occurring in care coordination that is not already being incentivized under the CPC Plus model outside of that initial primary care to specialist consult?
So I will start with that briefly, and then I think I'll defer to my colleagues, either Brian or to Suzanne, to see if they'd like to add anything, as well as my colleagues at NCQA. So the CPC Plus model, as you're aware, is focused on the primary care practices themselves, and it certainly does incentivize them through the requirements to work with their specialty colleagues. But the specialty colleagues themselves are not as engaged in that model directly. So this model really offers an opportunity to build on the CPC Plus model, as well as the forthcoming primary care first model, in a way that actively engages the primary or the specialty care practices and incentivizes them and rewards them, quite frankly, for engaging in a meaningful care coordination agreement with the primary care practice. So I'll jump over to Suzanne, who I think may have more to add on this, and then I'd also like to see if our NCQA colleagues would like to add more as well, given the recognition program that's engaged with this model for specialty practice.
Sure, thanks, Sherry. Just to add on to what you said, which I think is a really good point. You know, with CPC Plus, it specifically says that it's geared towards primary care physicians. So even though I think it's great that specialists are engaged in the model and often participating in care coordination agreements, they don't have formal recognition in that model. And they also, importantly, therefore, do not have the necessary funding to uphold a lot of these care coordination activities, you know, which do cost money. And so that's where we really see our model entering and supplementing that. And I'll also add that, you know, they are also able to participate in MSSP ACOs and other models as well. But again, you know, while they are allowed to share in those shared savings of those models, it's not required or guaranteed. And so MedPAC actually in their report specifically called this out as an issue, and they're seeing some specialty practices leave because they don't have sort of that financial investment in the model. So we really think that's critical and really a gap that our model aims to address. And just to add to that, one other point is that we certainly think there's a lot of evidence of room for improvement. At this point, only half of referring clinicians have any idea that their patient even actually sees a specialist. That's a problem, but it also gives us a lot of room to improve in that area. And so we think that building on these models and further improving the coordination between these settings and giving specialty practices an actual financial accountability is really the key to this model.
And also, I believe Brian Outland wanted to comment on this as well, and then we'll see if our colleagues at NCQA would like to add anything more.
Yes, and also one of the things that was actually intentionally built in this model is a triage of every referral that comes to the specialty clinicians. So they will triage every referral, and then they will see where the best service can be provided for each patient that comes to them. So it may be that then they can go talk back to the primary care physician and coordinate their care without having to bring them into the office, freeing up time for them to take care of their more initial patients that are sicker and those who they actually need to see. So it frees up their time and also gives them more communication back with every referral that comes to them, rather than just sending the patient back saying, you know, we don't need to see you or we don't have the appropriate information. But it allows them to have that open communication back and forth with the primary care clinician that refers every patient to them.
Thank you, Brian. I think that was an important point to add on. Michael or Joe, do you have anything to add as well from the NCQA perspective?
No, I think you answered the question completely.
I agree.
Thank you.
I don't see right now any of the rest of my colleagues with their hands up on my participant list here, but I had a question, or really sort of a perspective on this. I've practiced medicine long enough that I remember the bad old days when we were all on paper, and when I made a referral as an internist to a specialty practice, we went through some sort of insurance process. There was all this stuff that I would fax over, and then the patient would see the specialist, and I would get back most of the time a very thoughtful, dictated response from my specialist colleagues that I referred to. But it was a messy process. It was hard to ever understand after the very first consult visit what was going on in the long run. And when we went to electronic medical records, as bad as they were across the many things that had to change and all the things we've complained about, one thing that got better, because I was part of a multi-specialty practice, was internal referrals. That information was seamless, and it was much easier to refer that information to my colleagues, and they had the ability to see the information. But there became some continuity for those colleagues of mine that were specialists I referred to that were not part of my multi-specialty group, because it wasn't necessarily connected in a way that was easily able to transfer the records. That's a long preamble to say that as I was listening today, I was thinking of all the benefits that this model can do, and it very much support the idea not only of medical home, but medical neighborhood. But I would very specifically want to understand, as someone who advocates for integrated care and multi-specialty medical groups in many situations, whether this is a model that is much more specific for solo practices or independent practices, or whether you see this as being something that could be coordinated across the type of specialty practices, whether it was part of an integrated group, a health system, or just solo. Is this for small solo practices, or can others participate? And does it change if that's the case?
Grace, this is Mike. I'll take it, and I'm sure Sherry and the ACP team have some additional comments. First, thanks for your comments. And I haven't practiced in a few years. When I did previously, your experience mirrored mine. I didn't work in an integrated system, but where I had good colleagues who were able to complete notes and share them back with me, it made my job as an internist much easier. And I've tried to make their job easier by providing complete notes and with the actual question I wanted the specialist to answer. I think this model is trying to drive us towards that goal again, and really focus on the patient, the narrative, the needs of the patient as he or she moves through the system, whether that's a solo practitioner referring to a large specialty practice part of an integrated system or sort of affiliated with one, or vice versa, where a specialist is, large internal medicine group is looking for the local specialist. This model is flexible enough to allow and promote good care in both of those cases. And the referrals should be, I'll use the word healthier in the context that the information transferred is more complete. And the patients may not be healthier because you want to send the folks who need to be seen by the specialist and the specialist coordination, but that whole relationship around sort of the information sharing and coordination is healthier. And that creates efficiencies in and of itself. And that's what we hope to achieve through this model. Sherry, ACP, other comments?
Sure. I think that's absolutely right, Michael. And I guess I would just want to reiterate what Brian spoke about before, is this pre-screening that I think is unique in this model that really allows the opportunity for advanced coordination between the specialists and the primary care physicians, so that we're certain that that referral is appropriate and that there is, an expectation from the specialist when they see that patient that they will have the information that they need and that they will be able to provide the services that they need to provide to that patient. So I think that, and I think getting at this issue that the idea of this pre-screening, it also really allows that specialist, as Michael was saying, to be certain that they are seeing the patients that they need to be seeing, and that it will actually free up, I believe, access to that specialist for the patients that need to see them the most. And And I think that is a real meaningful outcome, I hope, that this model could provide, and ensure also the ongoing discussion and collaboration between that specialist and the primary care clinician over the course of treatment for that patient, so that we're sure that they really do know what's happening between, with that patient over the long term. And that coordination and communication is there as it's established through a care coordination agreement, and the infrastructure that both practices put into place through their work to achieve the primary care practice, to achieve the standards that they need to achieve to be a CPC plus practice or a primary care first practice, or if this were to expand, a PCMH practice more broadly, and that specialty practice, as they put into place those standards to be a primary, a patient-centered specialty practice. So I'll stop there. I don't know if any of my other colleagues from ACP have anything else to add.
And I'll just add quickly to those great points that I think another key factor of our model that makes it achievable and attractive to small practices is the scaled risk. And the fact that they can select their own level of symmetrical risk, because we've heard from our members, and I know this is a commonly cited problem, that one of the biggest barriers to small practices joining APMs are really high levels of static, immobile risk. And so I think the fact that our model starts where the practices feel comfortable and offers them opportunities certainly to take on more risk, and in exchange for more reward, there is that incentive to build towards that, but it's not required from day one. And I think that's really important to get small practices on board and help them feel comfortable with the model and attract them.
Thank you. I don't see any other hands raised right now. I want to just confirm from my colleagues that they have no further questions. Somebody can certainly shout out if I'm missing them. Hearing none, let's go to the public comment period. And we've got two people that have signed up today to speak from the public on this proposal, and just want to make sure I've got my list here. I believe that that the first person on the list is Sandy Marks from the American Medical Association.
Thank you, Dr. Terrell. Good morning. I'm Sandy Marks, and I'm making comments on behalf of the American Medical Association. I am strongly proposal from the American College of Physicians and the National Committee for Quality Assurance, and we urge PTAC to recommend it to the Secretary for implementation. The proposal cites data from multiple sources indicating the magnitude of the problem with poor coordination between specialists and primary care physicians. As many as half of referring primary care physicians have no idea if their patients ever actually see the specialist to whom they are referred. Specialists report receiving referral information for only about 35% of referred patients. These gaps in communication lead to delays in care, inappropriate care, and errors, all of which could be prevented with the coordinated medical neighborhood approach described in this proposal. We think it is also important to recognize that existing APMs, such as accountable care organizations, have not fixed this problem, nor have the existing Medicare medical home models. Existing models and the forthcoming primary care first model can provide much needed support to primary care physicians, but they have not been effective in supporting the specialists on whom patients depend to treat and manage complex conditions. The medical neighborhood model is scalable and can accommodate a variety of specialties, and we appreciate that it is starting with 3 key specialties: cardiology, neurology, and infectious disease. Our current experience with COVID-19 has provided many physicians with experience in e-consults, and it reinforces the advantages of their inclusion in this model as an option. Pre-screening through e-consults can avoid treatment delays that occur when patients are initially referred to the wrong to the wrong more urgent cases to be quick. here at one. Patient and care. Patients tell us that what is for their entire seamlessly instead of having to start from square one with each physician that they see. The medical neighborhood model can repair this fragmented system. Thank you.
Thank you, Sandy. Our next commenter from the public is Leslie Kosiemba from the American Academy of Neurology.
Good morning. On behalf of the American Academy of Neurology, I wanted to share our support for this medical neighborhood model and reiterate some of the areas we find particularly important related to it today. Neurologists have struggled to participate meaningfully in alternative payment models on neurology-specific items beyond stroke. And we believe the opportunity to use various neurology measures in the medical neighborhood model would be critical and relevant for neurologists in a PCSP practice. So to echo some of the PRT's feedback, and as noted several times today, we believe this not only relates to neurology, but is highly scalable to various specialties to participate where they may not have been able to meaningfully participate in APMs in the past. On that same note, we support the multi-payer structure of the model as it formally engages specialists in financial outcomes. Neurologists participate in care coordination activities often, but as noted by ACP staff, they're oftentimes not paid for this work as that goes towards primary care specialists instead of specialists. We also strongly support the model's flexible risk options with the opportunity to take on more risk over time. We have a lot of small and solo neurology practices that often struggle to visualize how they might be able to participate in value-based care models and alternative payment models. And so we find the flexibility options to be critical for engaging different practice types. We also support many of the specific care coordination elements in the models, especially the pre-screening process and optional e-consultation to resolve cases that don't require an appointment with a specialist. These elements not only enhance communication and consultation with primary care and specialty practices, but they value patients' time, as noted earlier, reduce unnecessary delay to treatment and waiting times for more urgent cases that are especially relevant now in the landscape of COVID and telehealth. We appreciate the opportunity to share our support and thoughts on this and look forward to continued collaboration in the future.
Thank you very much for your comments. Now I'm going to ask if there are anybody else from the public that would like to comment at this time. PTAC Amy is monitoring and can let people in through the operator. The other thing that I've just gotten a note from PTAC is that apparently we did not make it clear earlier that if anybody has any specific questions regarding this process or this particular model, that they can reach out specifically to ptac@hhs.gov. All right, I've got a message that there's no other public comments, so it's time for the committee to begin getting ready for voting. But before we do that, I want to just ask my colleagues, do they have any other comments or discussion before we get into the voting? I'll just give them a minute. Okay, hearing none. First, as our colleagues know, we vote on the proposal as individually as whether it meets each of the 10 criteria. The member votes roll down until a simple majority has been reached. A vote of 1 or 2 means does not meet. 3 and 4 means meets. 5 and 6 means meets and deserves priority. And the asterisk means not applicable. After we vote on all 10 criteria, we will proceed to vote on our overall recommendation to the secretary. We will use the voting categories in process that we've been using since December 2018. We designed these more descriptive categories to better reflect our deliberations for the secretary. First, we will vote using the following 3 categories: not recommended for implementation as a physician-focused payment model, recommended, and referred for other attention by HHS. We need to achieve a 2/3 majority of votes for one of these three categories. If the 2/3 majority votes to recommend the proposal, then we vote on a subset of categories to determine the final overall recommendation to the secretary. The second vote uses the following four subcategories. The proposal substantially meets the secretary's criteria for PFPMs. PTAC recommends implementing the proposal as a payment model. Number two, PTAC recommends further developing and implementing the proposal as a payment model as specified in PTAC comments. Or number three, PTAC recommends testing the proposal as specified in PTAC comments to inform payment model development. Or finally, PTAC recommends implementing the proposal as part of an existing or planned CMMI model. And then we would need 2/3 majority for one of these four categories. So now it's time for us to vote on the first criteria, scope, which is considered a high priority item. We appreciate your patience again as we get each member connected to the mobile technology for this voting session.
Grace, while folks are voting, I just thought I would mention, this is Jeff, that Dr. Feldstein had an emergency and had to leave the deliberation. So if folks are looking at the numbers, Grace, there'll be one less person voting at this point. Thank you.
Okay, thank you. Now I have now been able to enter for the voting on my technology. Do we confirm, is everybody else on? Anybody not on at this point? Okay, I'm assuming we're all on then. So our first criteria is scope. The aim is to either directly address an issue in payment policy that broadens and expands the CMS APM portfolio and includes APM entities whose opportunities to participate have been limited. I have not had a chance to vote yet. Apparently it got closed before I got in there. Not sure what that means.
So it's unclear because there are 8 votes that are showing. So do we need to revote?
I think we do because I did not vote. If I did, I didn't know I did. Let's do it again. Sorry, folks. Has it been entered?
We did, yeah, it's gone in.
So for some reason, we're seeing 9 votes instead of 8.
Might be possible that Dr. Feldstein is voting. I'm not clear, but I got a message that he's voting, potentially. You have to confirm. Thank you.
Okay. Can someone please confirm that?
He is not available, so let's try the vote one more time. Thank you.
So there's 8 that. There's 8. Okay, so we're ready for the results, Audrey?
So for criterion 1, 1 member voted 6, meets and deserves priority consideration. 3 members voted 5, meets and deserves priority consideration. 3 members voted 4, meets. 1 member voted 3, meets. 0 members voted 2 or 1 does not meet. And 0 members voted not applicable. The votes roll down until a majority is met, which is 5 votes. And so the majority has determined that the proposal meets criterion 1 scope, which is a high priority criterion.
Okay, let's go to criterion 2. This one is quality and cost. It's also high priority, anticipated to improve healthcare quality at no additional cost, maintain healthcare quality while decreasing cost, or both improve healthcare quality and decrease cost. Okay, Audrey.
Okay. 0 committee members voted 6, meets and deserves priority consideration. 0 committee members voted 5, meets and deserves priority consideration. 4 committee members voted 4, meets. 4 committee members voted 3, meets. 0 members voted 2 or 1 does not meet, and 0 members voted 0 not applicable. So the majority has determined that the proposal meets criterion 2, quality and cost.
Okay, thank you. Let's go to criterion 3, payment methodology, high priority. Pay APM entities with a payment methodology designed to achieve the goals of the PFPM criteria, addresses in detail through this methodology. How Medicare and other payers, if applicable, pay alternative payment model entities, how the payment methodology differs from current payment methodologies, and why the physician-focused payment model cannot be tested under current payment methodologies. Okay, Audrey?
So for criterion 3, 0 committee members voted 6, meets and deserves priority consideration. 0 committee members voted 5, meets and deserves priority consideration. 4 committee members voted 4, meets. 3 committee members voted 3, meets. 1 committee member voted 2, does not meet. 0 committee members voted 1, does not meet, and 0 members voted 0, not applicable. So the majority has determined that the proposal meets criterion 3, payment methodology.
Okay, let's go to criterion 4. It's value over volume, provide incentives to practitioners to deliver high quality health care. Go ahead, Audrey.
Zero committee members voted 6 meets and deserves priority consideration. 1 committee member voted 5 meets and deserves priority consideration. 4 committee members voted 4 meets. 3 committee members voted 3 meets. 0 committee members voted 2 or 1 does not meet, and 0 committee members voted 0 not applicable. So the majority has determined that the proposal meets criterion for value over volume.
All right, let's move to criterion 5, please. Flexibility. Provide the flexibility needed for practitioners to deliver high quality health care. Audrey, do the honors.
0 committee members voted 6 meets and deserves priority consideration. 0 committee members voted 5 meets and deserves priority consideration. 6 committee members voted 4 meets. 2 committee members voted 3 meets. 0 committee members voted 2 does not meet, or 1 does not meet, and 0 committee members voted 0 not applicable. So the majority has determined that the proposal meets criterion 5.
Criterion 6, please. Ability to be evaluated. Have evaluable goals for quality of care, cost, and any other goals of the PFPM. Okay.
All right. 0 committee members voted 6 meets and deserves priority consideration. 1 committee member voted 5 meets and deserves priority consideration. 2 committee members voted 4 meets. 5 committee members voted 3 meets. 0 committee members voted 2 or 1 does not meet. 0 committee members voted 0 not applicable. So the majority has determined that the proposal meets criterion 6.
Thank you, Audrey. Criterion 7, integration and care coordination. Encourage greater integration and care coordination among practitioners and across settings where multiple practitioners or settings are relevant to delivering the care to the population treated under the PFPM. That was quick. Audrey?
1 committee member voted 6 meets and deserves priority consideration. 3 committee members voted 5 meets and deserves priority consideration. 2 committee members voted 4 meets. 2 committee members voted 3 meets. 0 committee members voted 2 or 1 does not meet, and 0 committee members voted 0 not applicable. Because the votes roll down until a majority is met, which in this case is 5 votes. The majority has determined that the proposal meets criterion 7.
Okay, let's go to criterion 8. Encourage greater attention to the health of the population served while also supporting the unique needs and preferences of individual patients.
Are you ready?
Yes.
Okay. 0 committee members voted. 6 meets and deserves priority consideration. 1 committee member voted. 5 meets and deserves priority consideration. 5 committee members voted. 4 meets. 2 committee members voted. 3 meets. 0 committee members voted. 2 or 1 does not meet, and 0 committee members voted. 0 not applicable. So the majority has determined that the proposal meets criterion 8.
Wonderful, thank you. Criterion 9. Patient safety, aim to maintain or improve standards of patient safety. Okay, Audrey?
0 members voted. 6 meets and deserves priority consideration. 1 member voted. 5 meets and deserves priority consideration. 5 members voted. 4 meets. 3 members voted. 2 members voted. 3 meets. 0 members voted. 2 or 1 does not meet, and 0 members voted. 0 not applicable. So the majority has determined that the proposal meets criterion 9, patient safety.
Thank you. The final criterion 10, health information technology, encourages the use of health information technology to inform care. Okay.
0 members voted. 6 meets and deserves priority consideration. 2 members voted. 5 meets and deserves priority consideration. 4 members voted. 4 meets. 2 members voted. 3 meets. 0 members voted. 2 or 1 does not meet, and 0 members voted. 0 not applicable. So the majority has determined that the proposal meets criterion 10.
Okay, so we finished the first part of our voting. Audrey, do you want to summarize the voting on the 10 criteria, and then we'll go to the next phase?
Sure. The committee finds that the proposal meets all 10 of the 10 criteria.
Thank you. Okay, so we are now going to the next part of the voting. Thank you again. So this again is electronic voting, but the 3 categories that we're going to vote for are not recommend for implementation as a physician-focused payment model, recommend, and lastly, refer to other attention by HHS. So we're going to need to achieve a 2/3 majority of votes for one of these 3 categories. And if a 2/3 majority votes to recommend the proposal, then we'll vote on a subset of categories to determine the final overall recommendation to the secretary. And the second vote is for the following criteria. I don't know where I'm supposed to stop there or not, but let's go ahead and do this part of it and either vote for not recommend, recommend, or refer to the other attention by HHS. Wonderful. So Audrey.
So all 8 members voted to recommend the proposal.
Okay.
So that means we move to the second stage of voting to specify
Okay.
which category of recommend.
All right. So in the second stage, the vote is the following 4 categories. First, the proposal substantially meets the Secretary's criteria for PFPMs, and PTAC recommends implementing the proposal as a payment model. The second category is we recommend further developing and implementing the proposal as a payment model as specified in PTAC comments. Thirdly, it's to recommend testing the proposal as specified in PTAC comments to inform payment model development. And lastly, PTAC recommends implementing the proposal as part of an existing plan CMMI model. So we need a 2/3 vote for these 4 categories. So let's go ahead and vote on that now. Okay, Audrey, it's a little harder this time.
Yes, it is. So 1 member voted to implement the proposal as a payment model. 2 members voted to further develop and implement the proposal as a payment model as specified in PTAC comments. And 4 members voted to test the proposal to inform payment model development. And 1 member voted to implement the proposal as part of an existing or planned CMMI model. You need a 2/3 majority, which in this case with 8 members voting, excuse me, my phone is going off, with 8 members voting would be 6 votes, and you don't have 6 votes in any bucket. And so I would ask the vice chair if the committee would like to have more discussion.
Yeah, so I have gotten 2 or 3 chat texts from individuals while we saw these results saying that a couple of members at least were on the fence. I know I was and would like to revote. So I'm going to ask that it be opened up so that we can revote on this. Aha. Okay, I think we got to most of a consensus. Audrey, do you want to, that's a little easier. You want to summarize that?
Okay. So now 0 members have voted to implement the proposal as a payment model. 1 member has voted to recommend the proposal for further development and implementation as a payment model. 7 members have voted to test the proposal to inform payment model development as specified in PTAC comments. And 0 members have voted to implement the proposal as part of an existing or planned CMMI model. So the finding of the committee is that the proposal should be recommended and for testing the proposal as specified in PTAC comments to inform further payment model development.
Thank you. So the next part of our process is that I'm going to ask specifically each of the members of the committee to state how they voted, and then based upon that, with any comments, we can begin to guide the discussion on how we would like to construct advice to the secretary in the letter that we put forward. So I'll start with myself, that I voted to accept the proposal, and originally I was the one who was thinking about it within the context of putting it directly into another CMMI model, obviously the CPC Plus, but moved it with the majority to the category that we all chose. And I'll turn it over now to Jeff, and I'm just going down the list of people I have here in the order. As to Jeff, if you could state what your vote was.
Yeah, so I was the outlier. I voted to further develop and recommend implementation. And I was going back and forth. I know that testing has been a challenge when we have recommended proposals in the past for testing. I thought that I wanted to send a clear signal of support that while it needs further development, it's clear, and the submitters have said as much, that it is as complete a proposal as any one proposal that has come before this committee. And so I felt that voting to recommend its implementation, understanding that further development was necessary, was the appropriate position, in my opinion. But they're acknowledging that there's a lot of overlap between where the committee ended up, which is testing and further development. I'll leave it at that.
Okay. Jennifer, do you have any, how did you vote? Do you have any specific comments you want to make sure that are emphasized?
Yes, thank you. I did recommend testing, but agree with Jeff's comments around intent and that the category of further development also is one where I had internal debate about where to align. My comments are, what the PRT surfaced, and that's that there are, one, this is a really important model, and appreciate so much the work of especially societies over a long period of time to keep refining the proposal. But the comments around attribution, opportunities around what I'll describe as model harmonization or APM harmonization of different models that have been in play or currently in play, and this idea of incentives to participate, but also balancing accountability are ones that I believe still need to be worked out, as many have described.
Thank you. Kavita, how did you vote, and what comments do you want to emphasize?
Yes, thanks, Grace. I also voted the third category for testing for implementation and develop further. And I was also someone who switched categories. Honestly, I stand by what we said in the PRT. So my comments to the secretary would be to not confuse the recommendation for testing to mean that we think that this is, or that we think that this does not have merits to be a full proposed alternative payment model, that it requires some of the further deliberation that we outlined in our PRT report, particularly around attribution, payment methodology and potentially the quality measurement issues. So that's it. Thanks, Grace.
Thank you. Paul?
Thanks, Grace. Yeah, I voted to recommend the proposal and also voted to test the proposal to inform payment model development. I also was back and forth between further development, testing, and as others have already articulated, I struggled around the word test, as has already been pointed out. Really, this, as was emphasized by the PRT, is a pilot. I mean, that's what the submitters have said, and that's clearly in the thinking around the PRT, and I think the committee, that it's a pilot because there are issues that need to be worked out. The model is far enough along that it does warrant implementation, but there are significant issues. In addition to the attribution issue, which has already been brought up, and the APM overlap, the other concerns I continue to have is around the proprietary nature of the certification recognition program. I think as this potentially is implemented, there needs to be an alternative to requiring that certification. And I think as part of the further development around the care coordination fee and fleshing that out further on the payment side. And then finally, I'm not convinced that cardiology, ID, and neurology are the three best to start with necessarily, for a variety of reasons, but, consider other specialties such as endocrinology and nephrology, where there's, again, I think lots of opportunities for better care coordination. So those are my comments.
Thank you, Paul. Angelo?
Yeah, I, like everybody else, waffled between testing and further development, but landed on testing. And for the same reasons everybody else has already mentioned, I think, and I don't, as somebody else said, don't want that to be perceived as a lack of support for this APM, but just feel like issues like attribution, et cetera, that have already been discussed, needs a little further due diligence before it's actually implemented as an APM. Thank you.
Bruce? Not hearing you, Bruce. You on mute?
I tried to
There you go.
Can you hear me now?
Yeah.
Okay. I changed my vote from 2 further development to 3, but still have some concerns of the kind that others have mentioned. Attribution, risk adjustment, benchmarking for payment purposes. If you'll recall some of our prior conversations with the actuaries, these are the things that make them as nervous as a long-tailed cat in a room full of rocking chairs. That's for you, Jeff. And so their concerns are always well-founded. And so I think that all those elements of the kind that give the actuaries concern really need some attention as this model goes forward.
Okay, thank you. Lauren?
I chose testing primarily in interpretation of this proposal being a pilot, as well as, in addition to the comments that have already been made, differentiating attribution of the outcomes related to care coordination, and also teasing out the difference between specialty intersection with the patient around acute episodic events versus longitudinal engagement and differentiation of the care coordination aspect related to that.
Thank you. And I'm now just going to open it up one more time for any other comments any of us would like to make, since as we've heard each other speak and communicate. And then after that, we'll hear from Karen Swintek about sort of some of the things that she can summarize for us about what we were saying. So any other comments, having heard from each other now? And speak up. Don't feel like you have to raise your hand per se.
Okay, this is Jennifer. Sorry, I was just raising my hand. I believe this is the first time we will be sending materials to the secretary that includes an expanded environmental scan. And so it might be worth making a comment about the optimized process we have with regards to evaluation of many components, not only from a scan of practice, but also an expanded financial analysis. So I thought we might want to call that out explicitly.
Excellent. Any other comments like that, or different, or any disagreements with anything anybody said? One thing I would like to make sure, I suspect it will be emphasized, but I just think that this was one of the reasons this was so favorable is, at least from my point of view, is that it was addressing two things at once: the need for coordination of care between primary care and specialty, as well as the fact that it is alternative payment model that particularly addresses the dearth of such models within the context of the current options that are out there. So I'm hoping that both of those things will be emphasized in the report, as well as, from my point of view, the fact that this is proposed to be integrated into another payment model already out there and being developed and beyond the testing site is in and of itself something that could be valuable and a way of actually accelerating in the future others who are thinking about getting their own payment models adopted as to whether they could be part of a payment arrangement that's already underway, either through CMMI or through something else. The former head of CMMI, when Adam Bowler was talking to us about things, he spoke about many of the things that had gone through PTAC quite possibly could be part of another alternative payment model that was already being tested. And there were various opinions about that among the commission at the time, but this is actually from the field, someone actually proposing just that. So I think this is a unique opportunity to see if that approach of thinking about things that are already underway and adding them to a broader sort of development process, that could be something that's unique. So that's just one thing I want to make, not nearly as wordy as I just said, but maybe could be focused on a little bit within the report. Other comments? Okay, then I'm going to turn it over to Karen Switek to share an overall overview of the members' comments. And if you're ready, Karen.
Thank you. Can you hear me?
Yes.
Okay. So to briefly summarize, overall, the committee feels that the model addresses the important challenge of compensating specialists for engaging in care coordination with primary care providers, which could have a significant implication for cost and quality. The committee notes that the model has a number of strengths, including addressing the dearth of available APMs for specialists, and the report will note that the model will provide a framework for specialists to participate in alternative payment models and has the potential to eventually scale to additional specialties after the initial pilot. And I will also note that there's some discussion about testing the model in the context of the pilot, which may include an expanded financial analysis. The committee also noted a number of areas where the proposal can be further refined during the model pilot. Some of those nuances to be addressed during the pilot phase include issues related to payment methodology, including further development of the care coordination fee. Also, the concern that further refinement is needed to the attribution methodology to address model harmonization and the potential for model overlap with the CPC Plus and PCF models, and the potential for duplicate shared savings payments. And finally, the proprietary nature of the PCSP recognition process merits some further consideration. So the report to the Secretary will also include some specific comments from the discussion on those issues, but we'll note that the pilot will provide for the opportunity to address those nuances in coordination with CMS.
Thank you. Good job summarizing all that in real time. And let me once again offer my, and on behalf of PTAC, our sincere appreciation to all the submitters from NCQA and ACP for the excellent work you did and the thoughtfulness as well as your perseverance in bringing this back to PTAC. And we look forward to getting the letter out to the Secretary so that we can have your efforts continue to bear fruit. So that, I believe, is the end of the public meeting until this afternoon, when we will come back for a second proposal to evaluate. So this is a break time for the public until I think 1:45 Eastern Daylight Time. So we look forward to all of you this afternoon when we come back from that.
Thanks, everyone.
Produced by the U.S. Department of Health and Human Services at taxpayer expense.